Hi, this is Emma Krasansky in collaboration with Dr. Christopher Steele presenting the Health Equity Teacher Module, an anti-racist approach to medicine. The objectives for this module is that by the end, learners will be able to define anti-racism and explain the significance of being anti-racist, and discuss steps that healthcare professionals should take in order to practice anti-racist medicine. So let's begin by defining anti-racism. According to one of the experts in the field, Professor Ibram X. Kendi, an anti-racist person is one who is supporting an anti-racist policy through their actions or expressing an anti-racist idea. An anti-racist policy is any measure that produces or sustains racial equity between racial groups. And an anti-racist idea is any idea that suggests racial groups are equal in all their apparent differences and that argue racist policies are the cause of racial inequities, not the racial groups themselves. So that leaves us with this definition of racism, that anti-racism is a powerful collection of anti-racist policies that lead to racial equity and are substantiated by anti-racist ideas. That's according to Professor Ibram X. Kendi. So in this presentation, we'll be talking about how us as medical professionals can practice anti-racist medicine and how can you be anti-racist. We'll get into a lot of details in how to do so, but in short, admit when you're being racist and then challenge those racist ideas. But before we go on, let's discuss why being anti-racist is so important. Here I have a couple quotes that Ibram X. Kendi has put in their book, How to Be an Anti-Racist, that really illuminate the importance of anti-racism. So the first, the opposite of racist isn't not racist, it is anti-racist. There is no such thing as a not racist idea, only racist ideas and anti-racist ideas. One either believes problems are rooted in the groups of people as a racist, or locates the roots of problems in power and policies as an anti-racist. The construct of race neutrality actually feeds white nationalist victimhood. Now, these quotes all point towards the idea that there's two sides, either racism or anti-racism. There's no race neutrality. There's no being, I'm not a racist. Whatever you say, whatever you do, whatever you believe in, it either supports equity in anti-racism or inequity in racism. And for marginalized and minoritized people to live healthily and thrive, the individuals and institutions in our society must be anti-racist. They must support equity in all aspects, because if they're not, then whether they're actively being overtly stating racist things and supporting racist policies, or whether they're being race neutral, that is all racist, as opposed to actively being anti-racist and promoting equity for everyone in the healthcare field, that is promoting health equity, as well as societal equity for our patients. So how do we practice anti-racist medicine? In the beginning, I said in short, you identify racism within your thoughts and actions and challenge that. But that's easier said than done to begin with. And this does require effort, work, and commitment. And there's several aspects of practicing anti-racist medicine, many more than are probably included in this presentation. This is an overview and introduction, and I encourage you to do your own research after listening to this and get more involved yourself. So the first step is educating yourself. You have to be able to understand and value the legacy of racism in American medicine in order for you to avoid perpetuating it in your own medical practice. So there's been a false narrative of Black and other minority biological inferiority used to justify unequal treatment and human rights abuses for centuries, that we need to combat through our education. There is professional exclusion of Blacks and other minorities historically that we need to combat. There's silence and inaction regarding racial injustice that we need to combat and start being vocal about. But we can't do this without learning first. So you can do this through reading, through podcasts, through research articles, through talking to people, colleagues, patients, populations. And there's so many different ways too. So figure out a way that you think works best, choose a few, and really commit yourself, spend time doing this. It is not going to happen overnight. And there will always be new information out there. It is a continual learning process for everyone, including health professionals. To the right, I have some books that deal with health equity for minority populations, historically and currently, that have been recommended by several sites for recommendation for you all. But again, I recommend you do your own research in finding what books you may be interested in. The next thing that everyone needs to do in order to be anti-racist is admit to being racist. We must acknowledge racism within ourselves, our actions, our beliefs, our words, and our systems of healthcare in order to have the opportunity to challenge that racism with anti-racist interventions. This, again, is not going to happen overnight. You have to do some serious reflection on your actions or lack of actions as a bystander. Your biases, explicit and implicit, that have been ingrained within you over time through our systems and institutions of our society. Your beliefs, your affiliations that reflect upon you, as well as your privilege, your white privilege, if you're white, other privileges of being, for example, heterosexual, other majority populations. Reflect on those and reflect on how these impact your beliefs, your care, your practice, because how can you change what you're doing and become anti-racist if you do not reflect on your racism? Next is we also need to combat our implicit bias. Again, easier said than done. You'll find that's a common theme here. But implicit bias is preconceived notions which affect our understanding, actions, and decisions about others, and which operate beyond our control unconsciously. And it has been published that bias, stereotyping, and clinical uncertainty on part of healthcare providers does contribute to significant health disparities that exist in the United States, which is why we need to combat our implicit bias. The good thing is studies show that implicit bias is malleable. It can be unlearned and replaced with new mental associations. Doing that though is a long-term goal requiring constant attention and repetition, and it can be done through a combination of strategies. First, you have to identify the implicit biases that you have, and part of that is through reflection of your own thoughts, beliefs, of what I just discussed. Another thing that you can do is take implicit association tests. These are actual tests that can help you identify implicit biases that you may have of many different types. We have a few linked in the module syllabus for you to do and help you get started. There are intervention programs out there that are out there to help you rewire these implicit biases to include more compassion and understanding for minorities. We have one of those linked in the syllabus as well. Another part of it is continued self-reflection and active efforts to counter bias in your thoughts and actions. You don't just identify your biases and they go away. You have to continually reflect on your actions and how you're doing in combating those biases. And lastly, it's recommended that you slow down and pause long enough for your conscious thoughts to overtake the unconscious thoughts of implicit bias, and let your conscious thoughts dictate your deliberate and thoughtful words and actions, so that what you do is not, and what you practice is not, the implicit biases that may have been ingrained in us over time. Another part of being anti-racist is identifying and opposing racism. This may be within yourself, within your own actions and as a practitioner, your colleagues and peers that are practicing with you, or at the institutional level. At the individual level, you want to look for implicit bias that we've talked about, but also microaggressions. Microaggressions, which I have defined in a previous presentation. But again, these are the subtle comments, questions, remarks that are racist, but may not be considered racist by the person saying them, but they do affect someone who's receiving them. Both implicit bias and microaggressions can ignore, ridicule, and dismiss patient concerns, values, and beliefs, which is why we need to identify them and combat them to be an anti-racist. At the institutional level, you have to advocate for policy and legislation to promote equity in healthcare access. That could look so different in so many aspects because healthcare access is so general. So that advocacy could look like a ton of different things, but advocate for equitable access to healthcare. Carefully use racial identifiers only when they promote examination of racism that negatively attacks the patient well-being. Racial identifiers in medicine are highly talked about in terms of their usefulness, their appropriateness, and what some literature out there is saying is that racism is a social determinant of health, so race needs to be considered. But so racial identifiers should be used when there is racism potentially there and negatively attacking the patient well-being in the scenario. But if it's completely irrelevant and racism for sure is not at play, that racial identifiers may not need to be used as they could promote bias. So again, this is a careful consideration that you need to do in terms of needing racial identifiers. I would encourage you to do some more research on that, as there is some literature out there on where racial identifiers are going in medicine. Again, another thing at the institutional level is look for practices at your own institution that promote inequity and take action against them. This could be a variety of things, whether it's inclusivity and equity within patient intake and forms of the administration of your office, whether it's the resources that you provide your patients, the pamphlets, are they inclusive, are they representative? From the minute the patient walks in the door to the minute they walk out, and then into their self-management at home, your institution should provide health equity, and you are responsible as a healthcare provider at that institution for looking for sources of inequity and combating them. I love this quote from Ibram X. Kendi, who, as he says, and so I think every individual can look around their neighborhood, their own institution, and ask the question, well, who here is challenging the policy that is leading to these racial disparities? And they can join those people. They can join that organization. And if there isn't an organization, I suspect there probably is, or an informal group of people, then you create one. Then you become that organizer. Every single individual has the power to do that. The takeaway from this quote, I think, is that every healthcare practitioner has the power to make a difference, and that therefore they should actively look for health inequities and then actively combat them with existing organizations or through their own mechanisms. There's always an option. Another part of practicing anti-racist medicine is examining your own clinical practices. This one is more clinically focused. Many common diagnostic algorithms and practice guidelines adjust or correct their outputs on the basis of a patient's race or ethnicity. But many of the times they do so without sufficient data or appropriate context to provide rationale for that race correction. And then those race corrections and these tools can then cause decision-making and treatment planning that directs more attention or resources to white patients than to members of racial or ethnic minorities, which is why we need to be aware of them. And there are some examples out there. The first one, I have a couple listed here, and I won't discuss them all for the sake of time, but the American Heart Association Get With the Guidelines heart failure risk score. It awards 3 extra points to non-Black people in its algorithm. And this puts Black patients at a lower risk in the outputs of this algorithm, meaning that when it comes to heart failure risk, if they're at lower risk, these Black patients, according to this algorithm, but there's no actual biological mechanism that has been found between race and heart failure risk, then they are they've been identified as less need for care and resources, and this may be an appropriate deeming of lesser need and jeopardize their health. Another example is the estimated glomerular filtration rate. Basically, it's a measure of your serum creatinine that will dictate how well your kidneys are functioning, but it gives the algorithm output corrects for race and gives an increased estimated glomerular filtration rate for Black individuals, suggesting that Black populations have better kidney function. When again, there is no sufficient biological mechanism and context relating the race correlation to the outcome as causative, as relevant to that calculator. So by suggesting that Black individuals have better kidney function with this algorithm, there may be Black patients that go without referral to specialists when their kidneys may actually be having trouble, putting them at health risk. There are a couple more on this list here and many more out there. I recommend that you read the article about these algorithms that's included in the module in your resources to learn more about them, and do your own research for what algorithms are used within your area of practice, and see whether or not they are corrected for race, and whether there's the context and data to support that correction. In general, the research that's out there regarding this suggests that when developing or applying clinical algorithms, physicians should ask 3 questions. First, is there a need for race correction based on the robust evidence and statistical analysis? Is the data there to support a race correction? Second, is there a plausible causal mechanism for the racial differences that justifies the race correction? Correlation is not causative. Always. You have to do digging and establish causation. And causation is very important if you're going to be correcting an algorithm to dictate diagnosis, prognosis, risk based on someone's race. The race has to actually cause the difference in risk for it to be used in an algorithm. And lastly, would implementing this race correction relieve or exacerbate health inequities? By doing this race correction, how is it affecting your patients? That's the main takeaway. You have to make sure that how you're treating your patients is equitable, and many of these algorithms are not. So look into what tools you're using, do your research on how you're practicing, and make sure that you're providing your patients the best care that they can get. Lastly, practice patient-centered care. As always, we're encouraged to practice patient-centered care. Every patient and their experience is unique. That does not exclude our minority populations. Get to know your patients' backgrounds, their values, and their lifestyle in order to proceed with equitable healthcare that fits that patient's, their needs, and how they can manage their health. This includes preventative care, acute and chronic care, as well as considering and addressing the patient's specific social determinants of health, as we know that those are commonly affected by racism, and giving them the appropriate end-of-life care that they want, they value, and they need and they can have within their lifestyle. Just because we're talking about racism and health equity does not take away the basic practices we have as practitioners of practicing patient-centered care. So I encourage you to continue to focus on that with all of your patients. This brings us to the end of our how to practice anti-racist medicine presentation. Again, this presentation is an introduction. It does not have all the resources out there. There's so many, so I encourage you to go out there, learn about anti-racism, what it looks like in medicine, as well in other fields and general society, and put in the time and effort that's required for us to become anti-racist practitioners. It is a constant and ongoing effort. It's not going to happen overnight. So best of luck in doing that.